Welcome everyone to this webinar, Redesigning Pathways, Redefining Your Estate. My name's Daloni Carlisle. I'm a long-time contributor to the Health Service Journal. And first of all, I'd like to thank you for joining us today, and I hope you'll find some new insights to take away with you. We're going to be exploring the contribution that estates and facilities management can make to service redesign. We're here with an expert panel to explore this important dynamic. We have with us Tim Kempster, who's Director of Strategy at NHS Property Services. Some of his background coming up on screen now. He's got vast experience in both the private sector and in the NHS, where he's worked at national level over many years. We also have Caspar Ridley, who's the National Director for Health at Interserve, which is one of the world's foremost support services and construction companies. Again, years of experience of working with the NHS. And finally on our panel today we have Trevor Payne, who's Director of Estates and Facilities at Barts Health NHS Trust, which I'm told is the largest healthcare trust in the NHS. So first a few words from me, some thoughts to set this webinar in context. I think everyone listening will be familiar with the idea that the NHS needs to redesign the way services are delivered. And that's both to provide integrated care that patients want and to remain sustainable. That care has to take place somewhere, and it probably isn't where it's currently located. I think it's also worth reminding ourselves of just how much land the NHS owns. In 2013, the NHS Information Centre put it at 6.9 million hectares. That's over 10 times the area of the City of London. The total floor space of NHS Trust and primary care buildings, and that doesn't include primary care facilities like GPs, is estimated at 28.4 million hectares. Yet, as the King's Son pointed out in a paper in July this year, estates rarely feature in service redesign. Nigel Edwards, King's Fund Fellow who wrote that report, said, but he put it like this in his report, there's been little real attention given to how this huge resource could help to improve efficiency, move more care out of hospitals and exploit new technologies. Models of care are still designed around buildings, but could rethinking the way the NHS uses its estate catalyse change? Well, that's what we're here to discuss today. What are the opportunities and how can we unlock them? We want to hear what you've got to say about these issues and any questions you'd like to put to our panel. You should see a button on your screen and you can submit a question that way. We'll try to answer as many as possible as we can at the end of the webinar. But before we go ahead, I'd like to ask the audience two polling questions to set the stage. So you can respond to the question on the screen. So question one. Do you agree with Nigel Edwards at the King's Fund that too little attention has been paid to the role of estates and facilities management in service redesign? Take a moment to answer that. I'll be quiet for a minute while you have a look at that question and answer. Thanks very much for that. A second vote. Does estates and facilities management have a role in service redesign in your organisation? Really like to get a gauge of where you are in your organisations on this. So again, take a moment to answer that. It should be on your screen. So clearly the main point of today is for you to hear what our expert panel has to say. So it'd be great if we could start off with some presentations from those. So if I can move on to Tim Kempster, Director of Strategy at NHS Property Services. I'd like to invite Mr Kempster to talk us through the challenges and opportunities as he sees them from a national perspective. So over to you, Tim.
Thanks, Daloni. I just really wanted to put it in context the creation of NHS Property Services, because I think what it does is it exemplifies some of the challenges that we have with our existing estate. Obviously, the company was created on the 1st of April through the transformation process, and just by looking at the slide, you can see some of the bold statistics around the creation of the organisation. I think if we go on to the mix of the inheritance, you can see that a substantial volume of the property, as you would expect, is health related, big chunks of health centres and care homes. I think the issue we have is that as we move forward, we've got this mixed estate and we have got some extremely good facilities that we've inherited, but we've also got some that are inadequate, and there's also ones that are, as I say, underused, vacant, that need to be disposed of. So what we do have, prior to the re-engineering of the service, we've got to think how we deal with that legacy that we've received, because it still represents value. You know, there is value, there is cost in the estate that is almost certainly oversized and in many cases ill-suited to the challenges moving forward. We've obviously got a projected population growth, particularly an ageing population, and you know, the increasing requirement to manage long-term conditions. Put that against the context of increasing financial pressure and constraints on resources. Again, that's something that we've got to bear in mind. So the benefits we bring, we can bring in efficiency by applying economies of scale, and we can also not only apply more commercial rigour, but we are mandated effectively to start to apply more commercial rigour. But we do have to maintain our local relationships with the existing system and the developing system, and think about how we can apply more consistent approaches where it's the right thing to do. So where we are is, as an organisation, the company can provide some leadership. It can also do very specific things in relation to property, like ensuring that the stuff that is redundant is disposed of, and the money realised from that can be returned to the system as a whole. But obviously, we also have the fact that the creation of the company, at the time the company was created, there was an ineffective fragmentation of the system. So some of the levers and triggers that sat within the older system are now not necessarily within our gift. So we have to take a partnership approach to this system. So our expertise sits in property and facilities management. The expertise in developing new models of healthcare delivery sit outside the organisation. And what we've got to do is we've got to foster that partnership and make sure that we're working with people to actually get the right answer and then provide an estate or an environment in which these services can be more effectively delivered. And I think, we cannot, as an organisation, just go down the traditional route of a property company or a facilities management company. We have to look at more innovative models of ownership. We've got to think about how we match the pace of change that's likely to come through from this change in the delivery model, because clearly if we commit the system to very long-term investments in non-core property, effectively we're burdening future generations with those costs. So I think, just really to set the scene, we have to look at more sustainable solutions. We have to look at how we can work and provide more co-location of services. And I think part of that has got to be in the sort of the expectations of patients and the public generally, is that some of the services are provided in a way that much more effectively suits their lifestyle. And we've also got to think how we can partner with the NHS, the third sector, and commercial entities to deliver better value to the NHS. And I think that's.
Thank you very much.
If I can leave that there.
Yes.
Thank you.
Thank you very much. That's a really useful overview. I'd like to hand over to Caspar Ridley. I should point out Interserve is sponsoring our debate today. Thank you very much for that, for making it possible. Interserve has been working with the NHS over many years, and Caspar will now talk about how some NHS organisations are getting to grips with taking a more strategic approach to service redesign and estates and facilities management. Can I hand over to you, Caspar, please?
Thanks very much, Daloni, and thanks, Tim, Yes, I'm Caspar. Welcome to the webinar, and I'm delighted to be joining this debate, having recently joined Interserve following a number of years in health, in particular as an Executive Director and Chief Exec on the boards of 2 foundation trusts in the acute sector. We're particularly interested in this webinar because we're keen to explore the potential patient pathway redesign and its effect on the patient experience through estates and facilities management. So the boundaries between estates and clinical pathways are, I believe, coming to the fore. For example, we can look at patient hotels and in how we're delivering complex care in the home. We've recently done some market research with decision makers, senior decision makers across the health sector through YouGov, the market research company, over the summer. And this has highlighted the challenges facing those delivering frontline services, in particular over the next few years. Areas like acute care, community care and mental health services are also believed to face reductions in the quality and the availability of services. In health, from the survey, over half expect a reduction in scale and the quality of frontline services, and almost half expect reduced availability of services, and over a third the removal of certain frontline services by 2016. So these impacts mean that the way the services are delivered needs to change. One of the areas that concerned us from the people's responses was that they saw cuts to service delivery as the only answer, and that there was little consideration to sharing services between departments and bodies, doing things differently, and rescoping contracts to look at wider outcome-based solutions. The survey showed that 7% in health have no strategy to deal with the pressures facing the system. That 1/3 believe they will not have achieved their budgetary targets by 2016. And if you ask me, this highlights the challenges that the market's facing. But it goes deeper than just cutting services. Investment in the people to deliver those services is also reducing. On average, in health, they're expecting to make headcount reductions of 2.5% by 2016, and 2/3 in health expect to reduce training and development expenditure over that same period. Obviously, we are advocates at Interserve of the outsourcing model, and over half, or the majority whom we interviewed in the health sector, agree that the outsourcing model will be important to help achieve the targets. The property and estate is going to be fundamental in us helping to achieve savings, and as people need to make efficiencies of 8% by 2016 in their property budgets and 15.5% by 2020. And with a budget shortfall of 30 billion, we believe both the public and private sectors need to be jointly focused on delivering the best outcomes to society. The prevailing view is that services procurement and services delivery will be negatively impacted. 71% see a negative impact on the procurement of services, and 3/4 see a negative impact on service delivery. So the question for me is, can you save money whilst improving service delivery? And whilst I don't think there's a quick and easy answer, in our experience, we can highlight some areas where this can be done effectively, and a couple of those I want to share. We've been developing this approach through our work with University College London Hospitals and the UCLH charity to run the first UK patient hotel. This 35-bed hotel sees over 200 patients and carers a month use the facility, and Interserve, we provide the ongoing support. The synergy between the partners is paramount to creating a smooth patient experience and saves the hospital a significant sum, as it is 3 times more expensive in a traditional hotel compared to the cotton rooms at UCLH. The future of facilities management is about patient care and patient experience, in my view, and the creation of patient-centred care that is coordinated across the patient's pathway in and out of hospital. We have observed that by joining estate design, redesign, facilities management and a more patient-centric model of care, We can deliver enhanced utilisation of facilities and reduce the cost of delivering healthcare services. Our ability to deliver complex care at home through Advantaged Healthcare, for example, which delivers complex care to children and adults, as well as palliative care, head and spinal injury rehab, home ventilation and respiratory support, renal care and other things, means we can help reduce hospital occupancy rates, hospital inpatient numbers, hospital operating costs, and enable a greater level of clinical care in the home. Again, this sees, like Tim was mentioning, health, social services, private and the third sector working together to help improve the commissioning process. So smoothing the patient journey from hospital to home is a key challenge for commissioners, with multiple stakeholders often involved and with patients preferring to be treated safely at home if possible, which can of course be a win-win for everyone, increasing the patient experience and clinical outcomes and reducing costs to the NHS through innovative partnering. So both these concepts of the patient hotel and healthcare at home help highlight how important it is to consider the whole patient pathway, looking past individual budgets of individual departments within trust and other authorities. There clearly seems to be an opportunity to bring together the commissioning process and the care service to reduce costs and improve care. We can go further. We can extend service provision across the estates and facilities of more than one organisation. In Leicestershire, we've extended the service across CCGs and acute and mental and community health, where we're supporting over 550 buildings in the county and are developing a consistent standard of service across all FM services, whether that be cleaning, portering, patient catering, security, car parking, mailroom, waste management, restaurants, statutory controls, life cycle maintenance. The list is endless. I think it's the first of its kind in the UK, so it's inevitably challenging in bringing together different teams who may be used to different ways of working. But by joining up and sharing services, we can bring together the estate's transformation and facilities management, centred around the needs of the patients right across the NHS in this region. It will provide greater control and scope for consistency, quality and efficiency when delivering services, and potentially save the organisations in excess of £100 million, an ability to reduce occupancy levels by about 20% and deliver economies of scale in and through procurement. Having been an exec director and chief exec in acute trusts, I fully appreciate this can all be seen as a huge step. But where people take the opportunity, we are seeing evidence of savings and think there are new approaches the market can take to effectively redesign the patient experience. Thank you, Daloni, and back to you.
Thanks very much indeed. I can report back on our first vote. Over 3/4 of you agree that too little attention has been paid to the role of estates and facilities management in service redesign. I think that's probably not a surprise, but it does back up what others have been saying. Please do send in your questions. We'd love to hear them. But I'd like to move on with the discussion. Bring in Trevor Payne. Trevor, do you want to say a little bit about Barts and your approach to this dynamic?
Yeah, hi.
Hello.
Yeah, hello there. So Barts Health is a huge trust. I mean, it was created as part of a merger between Whipps Cross, Barts and the Royal London and Newham. It's the largest trust in the NHS. It's about 570,000 square metres of floor space spread across 6 hospitals. So we have huge amounts of property, and we're working through a process at the moment of trying to understand how we might reconcile that property, how we might consolidate that property, and also looking at the services that we've got, how we may follow a similar model to the one Caspar just outlined in Leicester in terms of standardising. We want one standard service specification, one way of delivering services, the Barts Health way. So that's what we're working through at the moment. So I think in many respects, Barts is a micro version of the NHS because we've got such a varied property portfolio. We've got perhaps the oldest hospital in the NHS and the newest hospital in the NHS when you look at some of the PFI schemes that we have as part of our portfolio that are still under construction. So we feel that we're able to sort of road test and route map things within Barts Health, which we think if they work for us, they'll work for the rest of the NHS. So there's a lot that we're doing at the moment, and I think one of the key messages for us is that one size doesn't fit all, particularly with the property portfolio that we've got. But, you know, there's a certainty around change, there's a certainty around consolidating the property and understanding the costs of the property that we've got. Thanks,
Trevor. Well, you said you've tried some approaches. One size doesn't fit all. I'd first question I was going to ask, we've started this debate by asking what are the opportunities, how do we unlock them? I was going to ask, what are the low-hanging fruit? Bit of a cliche, but what are the things that you have found that have worked? First of all, to Trevor.
Okay. Well, I've been at Barts for almost a year now, so I think the first thing for me is, and it's a real basic one, it's about understanding what you've got. So what property do you have? Where is it? How do you use it? How do you use it over a 24/7 period as well? So it's looking at ownership and occupancy and intensity of use. And it's then starting to overlay that with risk and backlog and the condition of the estate and trying to understand which buildings have we got that we would want to continue to operate out of, which ones do we need to put major investment into, and then linking that into the clinical strategy. I don't think that the estate should be driving the way that care is delivered, because at the end of the day, it's about wrapping a service, wrapping a building around the delivery of healthcare. But I think some of the low-hanging fruit, the simple ones, are about understanding where the risk is, understanding where the costs are, understanding how the space is used, and then you've got a platform to start to make some smart and informed estates decisions.
Thank you. Caspar, how does that sit with your experience? Is that something you'd agree with?
Yeah, I think in terms of the low-hanging fruit, as I sort of hinted at, I think it's about sharing best practice, about communicating, and about people having a little bit of courage actually to break some of the traditional boundaries. I mean, the NHS has been broken up into all sorts of autonomous units with their own governance structures, and sometimes it's hard for people to get out of those structures and talk and share and come together. So it can be done, and there are examples emerging from across the private and third sector of this happening, and within the NHS. So I'm confident, but it does require visible and courageous leadership, I think, sometimes, to work across boundaries.
Tim, over to you. I think one of the things that many people are looking to national organisations for is that leadership, is that bringing together of examples of best practice. Would you see your role being there, or perhaps in another way?
No, I mean I agree that we have to work, and I made the point in my presentation that we have to work in partnership and look. I think some of the initial low-hanging fruit for us as an organisation will be to sort of consolidate the estate wherever we can, and look at the opportunities to make sure, as Trevor says, the right part of the estate is utilised. So there's facilities out there that we've taken ownership of that are underutilised, that could be better exploited by the system, potentially freeing up the revenue for capital from redundant estate that can be reinvested in the service model. So I think that there is a significant opportunity there in reconfiguring, just straightforward reconfiguration of the estate. I think, again, we've got to look at how that estate is utilised, and that's how the services are provided, and whether we ultimately are looking at in overall terms, a smaller estate for the NHS, and done in a way that provides greater flexibility for service provision. I think the shift towards more healthcare at home and those sorts of things may well lead us to a lower level of commitment to the estate in its entirety, but ultimately we're creating a better environment for delivering healthcare services.
I'm going to move over to some of the questions that we've had now from our audience. A really interesting one, I think, and it harks back to the beginning opening statements. But question is, in the context of comorbidity, are you designing facilities that promote multidisciplinary use of common shared facilities such as wards and clinics, and providing integrated care? Perhaps you could talk about that from the aspect of Leicester, as I understand some of that kind of work is going on there, Caspar.
Yes, I mean, I think we're going to, with the parties all coming together now, to look at the strategy for the estate across acute, community, mental health, etc. There are a number of areas now that this would come under in terms of joint working. So I've seen also examples in my NHS days of GP surgeries coming into emergency departments in terms of almost partnering on integrated care across community and acutes on a particular clinical pathway. And I've also seen examples where you brought in a sort of healthcare at home type concept into wards, so they almost take over 3 or 4 wards in an acute hospital in order to sort of have an integrated approach back in to get people out quicker, if you like, and to reduce the length of stay. So to manage the flow of patients, if you like. So there have been a number of examples of integrated care working. I've not seen it on a systematic basis across the system, but there are pockets of examples out there.
And Trevor, I would imagine this must be at the heart of what is happening in some areas at Barts. Do you have specific projects that you've worked on in that area?
Yeah, I think the key ones that are going on at the moment is we're completing the final stages of construction on PFI. But I think the thing with PFI is that, you know, it was signed off and we started constructing a while ago, and healthcare and the way we provide healthcare changes. So in some respects, the buildings sometimes lag behind the models of care and the way you want to deliver services. I think the more exciting thing we're looking at the moment is integrated care and how we can spread that in terms of the community engagement and the community health service contract that we've got. I think in terms of designing the services and designing the buildings, I think we're getting to an understanding now that we need to do things differently. We need to look at the environment of where we deliver care, and that is more and more becoming closer to home. So we're looking at how we can group and aggregate services. So again, this is really relevant to the discussion today about estates and how we see estates and the buildings as an enabler to delivering healthcare, or something that gets in the way sometimes.
Yes, I think that brings us on to possibly to a second question. Do you think, it's a question from the reader, and I'll put it to one of you in a moment, do you think that NHS facilities and estates management can assist CCGs in implementing care at home or telehealth, and if so, in what way? Tim, is that a dynamic you've looked at?
Yeah, I mean, I think we can definitely support that. But again, it's how we engage with the system, with CCGs, to make sure that those, you know, it's not just a matter of throwing forward an idea. It's a way of evolving the system and making sure we're developing strategies that actually match that pace of change. So, you know, it's almost a plea for ongoing dialogue and make sure that we are matching our provision of assets to the need to redevelop and change service delivery. Ultimately, you know, if facilities become redundant, then it's for us to deal with them. Obviously, redeploying them, if that's appropriate, especially where there's a long-term investment, is good. But ultimately, moving into a home environment is likely to diminish the requirement for some of the dedicated clinical facilities, and you know, we've got to understand what those needs are and what that model is like, how that model is likely to develop as well.
Okay, well, I think that leads us into another one of our questions, which may be slightly pointy, but how easy is it to release costs by decommissioning an NHS estate? Tim, perhaps you could take that first, because I mean, I think it does tend to be something that is said, but how practically is it easy to do that?
It does depend, and I have to say, you know, that at some levels it becomes quite fraught with political difficulties. So I think the establishing that a facility is redundant for the provision of healthcare is one thing. Actually, then releasing the cost or you know, actually getting the value out of that can become a bit more tricky, because, you know, obviously there you do start to get localism coming into play, which is entirely appropriate, but equally sometimes the opportunity to directly put proceeds back into the system can be compromised by people going, well, you know, it's a local facility, we need to make sure it's preserved for that local area, and it's just getting the right balance and actually articulating the case for disposal or reassignment of a facility, so that we don't get you know, into a communications problem with the public, with the healthcare system about disposal.
Caspar, I may be wrong, but it does strike me that the model you've developed in Leicestershire may be part of the answer to this.
Yeah, so it's early days, and obviously we're all learning to work with each other closely on both the soft FM and hard FM, but also on estate strategy and developing a credible estate strategy which might release a significant amount of savings for the combined healthcare system, which of course is then reinvested back in the patient, of course, as that's what it's all about. So it is early days, but there are, it's definitely, we've got the right people at the table, and maybe that's one of the key things, is having the right people in the room, looking at the future, prioritising what clinical services are need to be delivered through which pathways. And then if you've got the right people in the room, that is part of the, you've won part of the battle then.
Okay, and I mean, who are the right people?
Well, I don't think, as I think we were talking about earlier, I think it was Tim, it's not just about estates. It should be about medical directors, it should be about chief execs of operations, and then there's obviously the link to the patients through the various groups that are formed within the new NHS structure. But critically for me, it's about not just estates directors, but also strategy directors, medical directors, etc., also being in the room. Because there's an awful lot of passion about this subject, but it's very hard to get things done. And the worry is that there's a fear of political or public backlashes at closing anything. When in reality, if the case is presented really well, and if everyone believes that will deliver a better clinical outcome, then it's worth having a crack at it.
We've started to get some really interesting questions in. Two of them I think are quite linked. One of them says, I'll read it actually, let's unpick it in a bit. Real estate is managed on a basis of per care provider. Can we redevelop the model so that it's a central model and not a local model, so that common skills for estate management can be shared and a common strategy be formed? Second question is, can a care service based on NHS model only be created using the private sector to manage and provide all the estates? I think these two questions are coming really to the same conclusion. Do we need to move out of very local provision of NHS estates and facilities management to something that's more strategic, whoever provides that? Trevor, what would your take on that be? How would you feel if you suddenly had a London estates and facilities management directorate?
I think there's definitely opportunities. I mean, scale brings benefit. It also brings some complexity sometimes. But I think there's definitely some opportunity to share best practice and to get some common skills and common approaches. I mean, it's something, when I worked at UCLH before joining Barts, I was looking at with UCLP as part of an academic health science centre, where we had a group of hospitals that were all part of that network, that were all buying services and all had property. We were doing things in different ways. We weren't often communicating. I think there's a huge opportunity to share and to standardise and to sort of industrialise the way we attack and approach common day-to-day issues. And that can also roll out to the estate as well. We all use it in different ways to different levels of effectiveness. In terms of the model, I think it could work. I mean, in some aspects, we've got that with property services. We have now a view around a whole property portfolio and the ability to standardise and to manage that across the UK, but it's early days, and as was said before, Tim and these organisations have inherited quite a mixed bag, and I think they need to work through some of those issues first of all before we'll start to see the real benefits of that type of approach, where you have got one organisation looking at a whole load of property and services.
Mm-hmm. Well, Tim, over to you on that question. What's your take on the ability to have a strategic overview, to pull things together, to reduce some of the costs through that scale, to provide all the expertise in one place? What would your take on that be?
Well, I think there's certainly there's common themes that should result in a level of standardisation across, from our perspective, our portfolio, which covers the whole of England, and I think those sorts of things are common professional approaches to property management. But by the same token, you've got to look at what opportunities exist in in sort of local areas. So there is a genuine need for a balanced view on this, and that you shouldn't sort of take a dictatorial view and impose just one standard across the country, because clearly there are differing needs. So you made reference to a London directorate. Well, potentially you could go that route, but clearly the conditions and the expectations that prevail in London are entirely different from major rural areas. That being said, the standard of professionalism and the opportunities for using economies of scale can be applied in both areas, and so it's working out what model fits, accepting that there has to be a high level of professional standards applied across the entire portfolios. Sure.
That's interesting take. Have you seen examples such as we've seen in Leicestershire with Interserve, of everybody coming together across a wide area? Is that something that also exists elsewhere? Tim?
I believe those models are starting to be developed, but I can't give you a specific example sort of offhand. But I think that that is almost, I think the point I made in my presentation is the need for there to be a wider view of this, and I think there was a reference in the question that you asked, that you posed, was can the private sector provide an entire solution? And I think the answer there is no, but it can work in partnership, and I think the same applies when you're looking at a mixed model of delivery, where you also have private sector providers of healthcare working in conjunction with the whole system. But clearly those are relationships that have to be critically worked out, and you have to be very careful that you don't end up putting perverse incentives into the system that end up with sort of resource leaking away from the provision of healthcare.
That must be a real danger, yeah. So does this bring us to the piece that I think Nigel Edwards raised? One of his main questions he raised in his report was that we need a strategic property management function. I mean, again, I may be misunderstanding, but it would seem to bring in all of the factors that we've talked about. Do we need a strategic property management function? Caspar, why don't you answer that first?
Yeah, that's a big question. I think I've been fortunate to work in the private sector in big multinationals before, in Shell and Syngenta and other companies, and I just want to reassure everyone that this is exactly the same dilemmas that other private sector companies face, between centralising functions and going very local to where the customer is. And there's always a natural tension between those two aspects, and most chief execs of FTSE 100 companies are grappling with that, I'm sure, on a fairly regular basis. I mean, my view is you can't just centralise everything on estates, and you can't just push it down to the local regions as well. You need a mix, but what you do need to be clear on is what that mix is, and which is going to be in the centre and which is going to be at the local level, and need to communicate that really, really clearly, because we've got an NHS with so many independent organisations and their own governance structures with members and councils and governors and boards and blah blah, all this sort of stuff, then it's really important everyone's clear who's responsible for what. So at the moment, and then my second view is that these examples of best practice, and there are so many, you just need to look at the HSJ awards and all those different great examples and the shortlist, that they are out there, but for some reason the NHS doesn't always seem to be very good at then rolling them out across the country and saying, actually, that's a great idea locally, that one would work nationally. So there's some challenge around everyone thinking that someone else is going to come up with a solution, either at local level thinking it's going to come from centrally, or centrally that it should be done locally. So I think communication is really key on who's doing what here.
All right. Tim, well, same question to you. Do we need a strategic property management function?
I think we do, but it has to reflect those local needs. So, I think it sort of harks back to my previous answer, that you have to take the right view at the right level. And I do think one of the great opportunities that NHS Property Services does bring is to do exactly what Caspar said, is actually roll out best practice across the country, and sort of recognise the value of a model, even potentially adapt the model, the core approach to it in a model, and use it elsewhere. And I think that's very useful, because that tends to make the use of resource more efficient, and sort of you also develop a consistency in your investment model, if that's what you're taking forward, that you actually start to understand the market dynamic better, and you end up with consistency of solutions where they are appropriately applied. So absolutely, I think that there has to be that strategic oversight.
Okay, and Trevor, that same final question to you.
Okay. I think there's a bit of a conflict there. I think we need a standard approach which is competently applied, so I think we need to deal with the same issues in the same way, and we do need to share the best outcomes of some of that as well, and share evidence. But there's always that conflict between local strategy and national strategy, and they may not always be completely the same. There's also opportunity at a local level, and I don't think we wield this enough as an NHS, that there's opportunity with more local integration with local authority and with other sectors. And if we're looking at property, we need to get past barriers, and we need to think, well, why are we doubling up? Why have we both got big back office functions? Why have we both got HQ buildings and other support services that actually, with a willing mind and a fair go at this, you could really start to strip out some of that duplication as well. So I think definitely there needs to be consistency in terms of how we deal with the problem, but I think we need to think about this local versus national strategy.
Terrific. Thank you. Well, we're unfortunately running out of time. I'm sure we could have a much longer running debate, but I've got a couple more polling questions for listeners. Having heard the debate, what are your thoughts on whether the NHS should develop a strategic property management function? I'm sticking the vote up on screen now. It should pop up in front of you. So perhaps take a moment to answer that. And then I'm just going to put one very last question to Trevor while we do that. From your position, sitting on a trust board, a very large trust, how do you start to influence trust boards? What do you say that makes a difference when you're talking to your chief executive finance director? How do you frame the arguments?
I think the first thing, and it's a bit of a no-brainer, is find a voice and understand the language of the board. So as an estates professional, don't talk in kilowatts and square metres, talk in strategy terms and healthcare and outcomes, and how the estate can support those outcomes. I think the other thing that really gives me an in is to be really clear about risk and backlog and things that are going to affect the way that we deliver services and how we might start to mitigate some of that investment or some of those risks. So I think that's really my in to this sort of strategic discussion.
Okay, thank you. And I've got one very last question for the audience, which is what single factor would help you most develop a strategic property management function? I'll start that again. What single factor would most help develop such an approach in your organisation, by which I mean a more strategic approach to it? I've given you a list of options, better understanding at board level, investment in training and skills for estates and facilities managers, for you to be more involved in service redesign, outsourcing with a partner or partnership working across whole health economies. Pick an answer. Tell me what you think is most important to you. And while you're doing that, I'm going to say thank you very much to our expert panel, to Tim Kempster, to Caspar Ridley and to Trevor Payne. Thank you so much for joining us today. I think it's been a really fascinating debate. I think there's been a lot of agreement here that we need to see better involvement of estates and facilities management in service redesign, that you bring a lot of expertise to this, but by being involved early, that we need to broaden our view. We need to broaden the partnerships that we work in. Thank you all so much for joining us to listen. I hope you've taken away some new insights. And thanks finally to our sponsors, Interserve, for making today's events possible. Goodbye. You can have a chance to look at this HSJ TV over the next year. Encourage you to have another look and to get your colleagues to look at it too. So thank you and goodbye.